Welcome to a presentation on myocardial perfusion imaging, assessment of left ventricular dyssynchrony, and to guide treatment in patients in heart failure. I'm Ernie Garcia from Emory University, and please note my conflicts of interest. So here what we're going to look mostly is SPECT MPI, the use in LV dyssynchrony, specifically intraventricular systolic dyssynchrony. By intraventricular is meant just the left ventricle, the dyssynchrony or synchronicity within the ventricle. And by systolic, it's really looking at the onset of mechanical contraction. So the topics we'll discuss: heart failure in CRT, how we can measure left ventricular systolic mechanical dyssynchrony with MPI. Gonna emphasize mostly the technical aspects of phase analysis, including, but also talk about what are phase analysis clinical characteristics and how to use it to predict which patients will respond to resynchronization therapy, and perhaps how to guide how to place the lead in those patients. This slide shows us two types of left ventricular remodeling in heart failure. If we look here, this is an autopsy example of a patient that did not have heart failure. This is one that has systolic heart failure, and this is one that had diastolic heart failure, also known as heart failure with perceived ejection fraction. For the purposes of this presentation, we're going to speak exclusively about systolic heart failure. So here what you see is that the ventricle muscle has thinned out, and the chambers are both stretched and thin, meaning that the heart can pump enough blood, which is why the patient is in heart failure. By heart failure, we mean a term that describes that a heart cannot keep up with its workload, and that the body may not get the oxygen that it needs. Note that in patients with diastolic heart failure, you almost have the exact thing. Instead of being thin myocardium, it's thick myocardium, very thick. So the chambers are surrounded by stiff and thick muscle. So here what's happening is the heart can fill instead of can pump. But it's the same effect. There's not enough there might not be enough oxygen that the body needs. But again, we're going to talk about systolic heart failure for this presentation. Here we're looking at the relationship between the electrical wave, both from looking at the EKG QRS. So we're going to compare the electrical wave of activation and the onset of mechanical contraction. So you can see the relationship first looking at the electrical wave of propagation, that the electrical wave is moving from the SA node to the atrioventricular node, and from the atrioventricular node into the bundle of His, and at the bundle of His is separates into the left branch and the right branch. So what we're talking about is that those are the branches where the electrical wave is being conducted. As the wave goes through, it makes the muscle thicken, and as it thickens, it makes the heart contract, or the ventricles contract. So you can see that what is happening is when it gets to the bundle of His, it jumps to the apex, and from the apex it goes up to the base. So it's squeezing from the apex to the base. It's a much more efficient way of pumping the blood out in normal patients. Here we're seeing for the first time a display of phase analysis obtained from a patient. This happens to be a normal patient who the study was gated. It's just conventional gated 8 frames per cardiac cycle, and we see that the perfusion distribution from the SPECT study is normal. But what we see here is the phase polar map. And what do we mean by the phase polar map? This polar map is color coded to delay from onset of mechanical contraction. Here we also see the corresponding histogram And in this histogram, we're plotting 360 degrees, which represents the length of one cardiac beat, versus frequency in terms of number of pixels whose onset of contraction was at that particular portion of the heart beat. So when we look at it here, color coded, dark means early, bright means late within the LV contraction. So you're basically seeing the earliest possible in the spade normal patient. This is the bundle of His. It jumps to the apex, and from there it propagates out to the septum and the lateral wall. Now, in the histogram display, what we're doing is animating a cursor, and as this cursor goes through a color that is seen in the polar map, we're blacking it out in this polar map representation of the perfusion. So this would be where it starts, jumps here, and then it propagates to the septum and the lateral wall. So again, you'll see it. Wait till it comes around one more time. And as it clicks those blue colors, it starts there, it jumps there, and then it moves to the septum and the lateral wall. One more time, show you where it starts there, moves, septum and lateral wall. Now, as you'll see later, there's several parameters that we measure, but the main parameter that I'll talk about is the standard deviation in terms of degrees, which is the width in terms of standard deviation of this histogram. And we can also look at the bandwidth, or the number of degrees where 95% of this histogram pixels fell. Now, so the way that the technology behind this is, again, we use 8 frames per cardiac cycle. So for each pixel within the left ventricle, we track that pixel in terms of count change. And you can see here cardiac cycle in terms of the 8 pixels versus counts. And you're seeing that as the ventricle gets thicker, the counts go higher. As it gets thinner, it goes lower. And so we're looking at a thickening curve, and we're replacing the 8 discrete counts with a continuous curve, which looks like a sine wave, which is what you get using this mathematical tool called a fast Fourier transform, or an FFT, in particular the first harmonic, which happens to be a sine wave. Now, why the reason that this is true is because of the fact that we use the partial volume effect. And I'll show you a couple of phantoms, but this one here is just a phantom where we have an eccentric chamber. So this is supposed to represent the LV with thick myocardium, thin myocardium. Is filled with the same concentration. But as we go around that myocardium, we have determined that the change in counts is linearly proportional to the change in thickness. Now, before you saw an example of a very normal patient, this is an example of a very abnormal patient, and this is the polar map of the face, onset of mechanical contraction, and this is the histogram. So you can remember the other one was very thin. This one is quite spread out. So in the heartbeat, the LV is, there's onset almost throughout the entire cardiac cycle. The LV is not resting very much, and you can see the number of pixels with the various onsets. Now, so one aspect that this tool is trying to address is whether we can help in identify the patients that would respond to cardiac resynchronization therapy and actually guide the therapy. So here you see how abnormal the CKG looks in a patient with left bundle branch block. And so the idea here is that first, not only does the EKG not look right, but you can see the synchrony with your eyes of this ventricle by just looking at it. Now, so the idea is to put this 3-lead pacemaker, and you can see one lead goes into the right ventricle, another lead goes into the outside wall of the left ventricle, which is why it's called biventricular pacing. So the idea here is to convert, if it's done correctly, this CRT device senses the arrhythmia and sends signals throughout the same leads to resynchronize ventricular contraction, or in other words, make them contract at the same time. So now what you're seeing here in this dynamic animated display is onset here, then onset there, where the activation is taking place. And so if it's done correctly, the patients improve. Another term that's used is CRTD, meaning that's not only for synchronization, but also for a cardioverter defibrillation in the same device in case there's a bad arrhythmia. So the guidelines of indications for placing this device has been changing quite a bit throughout the years. So even if we go back to 2013, these were the guidelines then. Patients in sinus rhythm, and by the way, it's mostly what's still the case now. Patients in sinus rhythm, mostly in patients with left bundle branch block, you like to see a wide QRS with at least 150 milliseconds. Patients with low ejection fraction below 35, in class 3, class 4 New York heart failure categories, and this is despite adequate medical treatment, and this will then become a class 1 level of evidence A for treatment with synchronization therapy. Let's talk more about the technical considerations. So going back to the partial volume effect and how we said that we can measure thickening so reliably, is you can see here. So we're not actually looking at the movement of the endocardium or the epicardium. We're looking at the count changes within the left ventricle. And so you can see from the Phantom study that was done back in 1990 by James Gold from our lab, and that if you get a wedge phantom, let's say of plexiglass, and you fill it up with the same concentration inside this phantom, and then you look at the counts in this wedge, in the middle of the wedge, what you see is when you look at thickness versus counts, it's linearly proportional until you get to a certain point. What the mathematics tells us is the point here is twice the resolution of the system. So after that, there is no change in counts, even though it's getting thicker. But the myocardial thickening does take place within this 5 centimeters, meaning that it's very linear and very adaptable to the measurements that we want to do. So again, one question that comes up often is how can you possibly measure these millisecond changes when you're only using 8 frames per cardiac cycle? And people think that the temporal resolution is only 1/8 of the heart rate. But you see in this paper by Ji Chen at the time from our lab that he proved that with this fast Fourier transform approach and using the techniques that I talked to you about before, you can actually detect changes in onset of contraction within 1/64th of the cardiac cycle, which for patients with a 1 second per beat the temporal resolution would be 16 milliseconds. So 16 beats per minute, 1 second per beat. Temporal resolution will be 1/64th of that, or 16 milliseconds. Much better than 1/8 of the cardiac cycle. The other question is, wouldn't 16 frames per cardiac cycle give you better temporal resolution? In the same article, he showed that what is important, in fact, it's the number of counts per cardiac cycle. The number of counts per pixel within this LV count distribution. So here he did all these measurements with counts per pixel of 10 or 20, and even if the onset was different by 2.8 degrees, which is roughly 8 milliseconds, you can see that the error of using 16 frames per cardiac cycle with 10 counts per pixel, of course when you go to 8 frames you're going to get twice the counts. If you have fixed dose to the patient and fixed total time, you have to get twice the counts in 8 frames per 16 frames. You can see that the standard deviation is dropped significantly, and in fact the change is significantly detected here. Excuse me, it's between here and here that we should be comparing, and even when it's twice that or 5.6 degrees, again roughly 16 milliseconds, then it's between 2.7 and 2.6, and now the two of them become significant. But for smaller changes, the counts trump the more frames. Now let's continue to discuss quality control issues, and now we're looking at the quality control page from the Emory Cardiac Toolbox, which are the tools that I'm going to be talking about, the ones that have been developed in our lab at Emory University. So if we go to the QC page, we got to make sure of two things. Number one, that the gating was done correctly, and number two, that there are enough counts per pixel. So remember, in the previous paper, he was requiring at least 10 counts per pixel in the short axis images, and here we're looking at maximal counts in the short axis and maximal counts in the planar projections. But what's important are the ones in the short axis. And you can see that 120 is significantly more than the 10 or 20 that was used for the analysis. But these are the typical counts, the 10 or 20 or more that you get either on a resting or a stress perfusion study. Here we see in this analysis developed by Ken Nichols that we're plotting number of counts in these planar images versus the actual projection from each of the eight gates. And if all 8 count profiles fall on top of each other, it means that you're getting as many counts in this frame as you got in this frame or the last frame, which means that there are no gating errors detected, and you can trust the analysis. Now, in this article published by Russell Fox, also from a lab, he described how to optimize gated myocardial perfusion imaging processing for phase analysis. So here is even more important that the base be correctly detected by the algorithm that you're using, whether it's our tool or somebody else's tool. And we have provided some guidelines as to how this should work, and you can see that in this paper. But basically what you see is that for the base location, we depend on two things: the base at systole from the non-gated images, that is the composite image of the 8 gates, and the ejection fraction of the patient. In patients with ejection fractions greater than 50, we allow the base to move 2 slices from systole out to end diastole. In patients with ejection fraction between 35 and 50, we only allow it to move 1 slice from systole to end diastole. And for patients like the typical heart failure patients that we're talking about, we don't allow the base to move from systole to end diastole. So let's take, for example, this patient where the correct value with the automatic dictation was a base at 19 at slice 19, which, by the way, you want to look at the base for a backward C and at the apex for the cap of the LV without a hole in it. And this is the described in the Fox article. But the first question is, what happens if you put it out in 20? In other words, you move it too far out. And what you see, and we did them manually just to show you, you can see that we get this, looking at the polar map of the phase onset of contraction, we get a ring artifact. And with this ring artifact, you can see that the standard deviation for this patient is 72.2. Now the question is, what happens if we use the automatic developed one, detected one, and you can see that there's still some ring artifact, but it has been significantly reduced compared to the other one because now it's further in. It is sensing and measuring the thickening more correctly at the base, and you can also see that the standard deviation of the histogram has gotten narrower. Again, the patient is still in heart failure, but just to show you, and it's still abnormal, but just to show you how you can improve on these numbers. What if we try to optimize this further manually, having a 20 here and 19 in the other 6 gates? Now you can see that the ring artifact has almost totally disappeared, and the standard deviation has gotten down to 62. Again, still abnormal, but a much better defined histogram. And this is where we're tweaking these algorithms to show you in this patient. Clinically, it makes no big difference, but in other patients. Now, in this slide, we're looking at results from a paper by Yu Chen back in 2005, and we're looking at the mean normal phase distribution from many normal patients. And you see what it looks like. It's symmetric and it's narrow. And as I mentioned before, the two main parameters that we use, so I will not talk about the others, is the phase standard deviation, that is the spread in terms of phase standard deviation here, the standard deviation of this curve, and the histogram bandwidth, and which is how wide it, how many degrees will it take to define 95% of this histogram. And you can see that there are differences between males and females. For men, standard deviation 14 versus 12 for women, and histogram 39 versus 31. Now, understand that this is not the limit when you put in the standard deviations. This is not the limit of a patient that is in heart failure. This has been confused before in that this is the limit between patients that are very normal and patients that are beginning to become abnormal or dysynchronous. For patients with heart failure, we're going to have to do further analysis, which we'll talk about in a second. So here you see a patient now with left bundle branch block. And so you see, first of all, a histogram that is somewhat wider than that normal patient that I showed you before. But note that the standard deviation is still around 14, meaning that it's still very close to the mean normal. And again, that's to make the point that even though this patient has left bundle branch block and is roughly a little higher than the mean normal, doesn't mean the patient is in heart failure. But note that the pattern of the onset of mechanical contraction is different. It propagates different for this patient compared to the normal patient. So instead of starting in the bundle his and going to the apex, it starts at the septum and it propagates towards the lateral wall. So again, remember, this is the phase polar map, early and late. So it's moving from here out to there. Or if we look at this other at the perfusion distribution and we look at the dynamic display, sometimes called the marching ants. First of all, we know the reduction of counts in the septum due to the left bundle branch block, but now we also see that in general it starts here and it moves towards the lateral wall. I'll let it go one more time. Now, in patients that truly need to be resynchronized, like this patient here, first of all, note how wide this histogram distribution is, this phase histogram distribution is, compared to the previous patient or the normal patient. So this standard deviation is about 69. When this is done successfully, the results are remarkable. And note that this patient went from very, very abnormal Dyssynchrony to almost normal synchronicity. And thus, just by looking at the histogram, you can see when CRT has benefited the patient. Now, in terms of that, let's look at these two patients. So from the point of view of demographics, these patients look very similar. They're both in heart failure class 3. The EF is less than 35 measured by echo on both. But the question is, would both respond? And if one doesn't respond, why would they not respond? So you will see, you can note visually this patient is quite dysynchronous, where this patient is significantly more synchronous, even though it has a low EF. So what happens? This is the pre-CRT histogram, and for if the patient that you saw before that looked more synchronous, this is the one where it looked dysynchronous, and so the histogram reflects what you saw with your eye, but in a quantitative way, and you can see when this patient was resynchronized, it hardly, not only did it not improve, but his heart failure symptoms got worse because the patient was already synchronous. There was nothing to resynchronize. Where this other patient that was dysynchronous significantly improved not only in function, but also in heart failure class, from class 3 to a class 1. Now, so from looking at that, some years ago, particularly back in 2007, working with the group of Jerome Bax in the Netherlands with our team, we sought out whether we could predict, just based on this, which patient will respond to CRT. And by looking either at bandwidth or looking at standard deviation, we try to find the optimal point that best separated those who would respond from those who would not respond. And we came up with threshold, particularly for the standard deviation, is 43 degrees. And for the bandwidth is 135 degrees. Now, so even though we found the best cutoff, and this was retrospective, still we were in about the 30% of patients who didn't respond to these parameters. And so we got to keep looking. Just the synchrony alone is not enough to predict who's going to respond. So over time, the work of many labs, including Dr. Bax's lab, and in this case, working with us, looking at the implementation of phase analysis, it's been recognized that both putting the lead in the left ventricle in a region that is viable, and particularly in one of the last viable region to contract, will give you the optimal results. So here we're looking at two patients, and where the latest viable site, contracting site, compared to where the lead was placed, are concordant. This patient, and this is before therapy, in 6 months, this patient improved from an EF of 32 to an EF of 44%. Very significant improvement, and the improvement took place in terms of reverse remodeling. The ventricle actually got smaller. The end-systolic volume went from 139 to 86. Whereas when it was discordant, the last viable contracting segment versus where the lead was placed, this patient got worse from a 27% EF to a 22% EF, even though the patient was asynchronous to begin with, and the end-systolic volume remodel in the wrong direction, right? It got wider, and this was true when we look at 90 patients and with viable lateral wall, and you can see that when you look at baseline versus 6 months later, when it was a concordant result, the ejection fraction went significantly up. When there was a discordant result, there was no significant differences. Similar, when it was a concordant result, the end-systolic volume went significantly down. When it was discordant, there was no significant difference. So this is a single center retrospective study. So clearly, to establish this, this needs to be tested in a large multi-center. But to be able to test this widely in different sites, we needed to develop tools to do what I've shown you before, which could be done with your eyes or with other tools, but with a more integrated, sophisticated tools. So if you look at this patient, again, with left bundle branch block and in New York heart failure class 4, you can see significant perfusion defects. But if we look at the function, you see that the ejection fraction is quite poor, it's 11%, and very large in systolic volumes. Here what you're looking at is the thickening polar map, where you have a variety of thickening, including negative thickening or thinning, which tells you it's paradoxical, not only motion, but thickening. So if we then look at the Synchrony in this patient, we could try to look at it visually. First of all, we see that the standard deviation is 67 degrees, so it does exceed the 43 that we're looking for. So that's a positive for response. And then if we want to look at the last viable segment, you could say that you might be concerned here that it might not be viable. But as you see the onset of contraction, you can see either with your eye in the polar map that this is the last regions to contract, this being the very last one, but it moves through here. But if you look at it with your eyes, you would again see that if we start again, that as it goes through, it goes like that and it finishes here. So I will go one more time around to see that this is where it's going to end up in terms of the onset of mechanical contraction. So now this tool that we call the phase guidance tool gives you multiple display. This display here is a 17 segment display, and you're looking at the actual mean phase for that segment. So the larger the number, the later in onset of contraction for that segment. And you can see if you look at the possible segments where you are not allowed to put the lead either in the apex or the septum, you want a delay between the septum and the rest of the ventricle, you can see that perhaps this is the one where it should be placed. Now, so this is 186, 181, and 180. This is a viability display where the number tells you how many pixels are non-viable, or what percent of the segment is non-viable. So 100 means 100% non-viable, or the criteria is below 50% of maximum. And again, but basically it's telling you that all these segments here are viable. Now, again, this is apex and this is septum, so it will never be placed in any of those. So if you remember, we saw that it went the onset of contraction, the latest one were these two, and that if you look at segments, fixed segments, this will be the latest one, 186, and this will be 181. But if you allow that segment to move in this moving window, and you let it move anywhere, you can see this is the very latest onset of contraction for this viable site. So anywhere in there, one would predict a good onset of contraction and a good response to CRT therapy. Now, to show you how dramatic the results can be, and we see this quite frequently in these trials, we're looking at the change in a patient pre-post CRT, and this is a dramatic change, the type of patient we call a super responder. And you can see here, first of all, what the patient looks like with left bundle branch block, reduction of counts in the septum. Look how the counts improve post resynchronization in the septal wall. But also note that the synchrony is quite extensive, 64 degrees. Remember, we're looking for 43. And post resynchronization, it drops down to 16. So the synchronicity based on the histogram alone is significant. But look at the functional parameters. Pre-synchronization, the patient's ejection fraction was 25. Afterwards, it doubled to 50%. This is in a period of 6 months. The end systolic volume was almost 200, and it dropped to 111, almost also dropping by 50%, or reverse remodeling. So this is the type of response that we're all looking for in resynchronization therapy, and we'll continue to test these tools to see how we can get there. So just to summarize, the guidelines on how to do the CRT lead placement is evolving, at least in relation to implementing tools like the ones I just showed you from myocardial perfusion imaging. So it's still not accepted by many electrophysiologists, but this is why the work is being done to try to prove it to them. And so the guidelines that we think should be implemented is that LV must be mechanically desynchronous with the standard deviation greater than 43 degrees, less than 50% infarction, meaning that at least half the left ventricle has to be viable, and this is from other studies, that the LV lead should be inserted in viable tissue, that the LV lead should be inserted not only in the viable segment, but the one with the latest activation, that is the last viable segment to contract, that you require a technique that is consistent, so means that it's as automatic and simple to do as possible, so that experts in a core lab, for example, will get the same results that independent sites in different parts of the world would get with the same patients. And to prove all this, 2 major prospective trials are have just been completed. One supported by the IAEA on Vision CRT, called Vision CRT, and one finished in China called Guide CRT. And both these trials are testing the tools that I just mentioned. So thank you for your attention. Hopefully you benefited from this presentation. Thank you again.